one question I get for direct-to-implant reconstruction is, how do you know whether to go over or under the muscle? You may know that in recent years it's become more common practice to put the implant over the pectoralis muscle in an acellular dermal matrix like bra. Who can have that done and who should go under the muscle is traditionally done with just breast augmentation. So in my practice, what I've noticed is you get a lift when you put the implant under the muscle. It actually holds it up. Also, a lot of women will already have implants, and so you should keep it in the same location where the implant already is. So if you have a droopier breast or if you already have an implant in, often I'm putting that implant under the muscle. As you can imagine, the muscle acts to hold it as a coat hanger of sorts, so everything stays up. If you've never had an implant before, or you don't have any droopiness to your breast, or maybe just a little bit, you can cheat and you can actually take the mastectomy tissue out, and then implant is then placed under the acellular dermal matrix over the muscle. That means the pec muscle is never cut, and there's no motion of the pec muscle when you squeeze like this, as there will be if it's underneath. So patients good for that are people who have little droopiness, have never had an implant before, and you can actually slide the implant in a supportive dermal matrix over the muscle. People ask me, why doesn't everybody do this? Why doesn't everyone just go direct to implant? Or they'll say, oh, I went to this other location. I was told that I wasn't a candidate. So I think it's important for patients to understand what they're really hearing. Every mastectomy surgeon, now that's not me, that's the surgeon that does the mastectomy, has a different rate of having skin flap necrosis and nipple necrosis. You might be shocked to hear that there's a 30% rate of nipple and skin flap necrosis with mastectomy. So now if you ask surgeons to make an incision under the breast and you're actually removing breast tissue from underneath, what's the chances that it's going to be too thin or too thick, right? So it actually involves a decent amount of skill to be able to remove the perfect plane. Now, if you start to get too thin and they come up toward the skin, this disrupts the vascularity that's left feeding the nipple, and that's why unfortunately, nipple necrosis is fairly common. Now, if a plastic surgeon does direct to implant, you don't want the chance the nipple will die or that you'll have to remove skin afterwards because of blood flow issues. In that case, the plastic surgeon would do tissue expander reconstruction. So the risk is higher the bigger your breast is, the droopier your breast is, or the more worried they are about getting your cancer out. So I think it's important to remember that when someone says you're not a candidate, it means that patients like you, with a combination of that mastectomy surgeon and plastic surgeon, have done poorly. So I think you should be very careful how you hear things. Don't assign them to you. Assign that advice to those surgeons. And those surgeons, that's the procedures they should be doing. That doesn't mean you're not a candidate when another set of surgeons sees you. Many people ask me, will I need more procedures? This is a one-stage reconstruction. And so I would say about a quarter of my patients do undergo additional procedures. A common reason for that is fat grafting, because fat grafting is a softening agent, literally liposuction fat, processed, purified, and placed on top of the implant. They make the area warm, natural, smooth out any divots caused by the mastectomy. And also people who have had radiation often require a second procedure, since radiation causes tightening and hardening of the tissue, and placing fat into that area naturalizes, softens the tissue, and brings in stem cells. But many patients feel fine after the procedure, look fine after the procedure, and they're done and don't desire any additional procedures.